Hello. I thought it would be important to share my thoughts on the importance of preoperative optimization in the case of a new diagnosis of cancer. Many patients come to me after they've had lots of treatment, and I notice that treatment failure can stem from, in many cases, incomplete or inadequate preoperative optimization. Currently, many oncologists will recommend to patients that they have preoperative chemotherapy. Sometimes, in breast cases, it can be chemotherapy for anywhere from 3 to 6 months. And that's a long time to let a cancer continue to grow in the lifetime of a tumor. And we know that many tumors, it does take quite a long time for it to develop, and it can disseminate circulating tumor cells and stem cells in the years before you even know you have a cancer. So there's a microscopic component to cancer, and there's a macroscopic component, the tumor mass itself. So what I would like to recommend is that patients are educated about what are important factors and tests and pieces of information that should be gathered before decisions are made about treatment. First of all, it is helpful to understand what you're dealing with. And yes, there is the issue of the biopsy. I have many patients who come to me and refuse to take a biopsy. And of course, there are pros and cons. People think that if you have a biopsy, it's going to spread your cancer. And obviously, if you have a bad biopsy and too many needle passes, yes, it's going to cause more inflammation. It's going to create a problem with the tumor. However, it is very important to get the information of what you're dealing with. And in the case of breast cancer, there are certain aspects of receptor status that can become important and play an important role in guiding the treatment. For example, if it's estrogen receptor positive, progesterone receptor positive, or what they call HER2 or CERB1 positive. Now, why? Because there is immunotherapy that can be recommended for HER2 positive breast cancer. On the other hand, even with that information, a patient may be recommended to have a number of months of treatment before they come to surgery. Surgery in and of itself can be helpful for removing a primary tumor mass. However, anesthesia and wounding has some important aspects in that anesthesia can be immunosuppressive, and surgery is creating a wound. When you have a wound, it's going to stimulate stem cell and regenerative wound healing properties in your immune system. And in fact, it may help to stimulate the further growth of cancer in the borders of the resection if they are not fully clean margins, or even overall in the body. So the whole thing becomes problematic unless you take the approach of assessing what's there with some kind of imaging, especially a PET-CT scan is very, very helpful. Finding out what other underlying issues might have contributed to the person developing a cancer to begin with, especially when it comes to untreated viruses such as Epstein-Barr virus, parasites, fungi, candida, or any kind of chronic bacterial infection. All of these things play a role, and if they are diagnosed, they can be treated and optimize the surgical result by eliminating many of the inflammatory factors that are unnecessary. Now, also, there is an issue, depending on what type of cancer you have and where it is, of the inability of the surgeon to isolate the surgical field. So in the case of a colon cancer, you can identify where the lesion is, and there are many ways to operate upon them. Sometimes if it's a tumor that isn't through the bowel wall, the bowel can be easily isolated with clamps. You can isolate the vasculature, and then you can move that tumor and remove it without a lot of seeding into the blood vessels with the circulating tumor cells or stem cells. However, in the case of breast, that's not possible. Breast cancer has no discrete vascular supply. So the blood vessels can go medially to the internal mammaries, they can go to the axilla, they can go to the supraclavicular area, they can go posteriorly towards the spine, and they can go inferiorly. So it's a kind of a free-for-all. Anything you can do to coalesce that cancer and clean up the surrounding areas is going to be very helpful. The same issue in intra-abdominal tumors, especially when it comes to ovarian cancer. I had the occasion, very seldom, but to find someone who had a diagnosis of ovarian cancer. And usually this kind of cancer is disseminated all over in the abdominal cavity. The omentum, which is a little fatty sheath that hangs off the transverse colon, is usually involved because it kind of goes to areas where there are problems and picks up tumor cells. And the ovarian cancer cells are often studying the abdominal wall or into the peritoneum or mesentery, not just the lymph node involvement. So when I treated one case with a really nice preoperative, simple 3-week treatment, she had an excellent surgical result. Her surgeon was shocked to see that this tumor was just kind of tucked into the left lower quadrant in a kind of a ball, and nothing else was involved. You know, this is the type of thing we want to see. It's fine we want to remove that primary tumor mass. We don't want that to extend into other tissues. At the same time, we'd like to have it more, as I say, coalesced. I had another case with a large colon tumor. Individual had a very big tumor that was obstructing the large intestine to the point where he had to have a double colostomy to vent it above and below the mass because there was such a terrible obstruction. It was a large tumor. He was a very elderly gentleman, and he refused to have any kind of chemotherapy preoperatively, which is, of course, what he was recommended. So I treated him with some Chinese herbs and a mushroom called Agaricus blazei, morel, and another treatment that blocks the iron absorption of cancer cells. And this patient had a near miraculous shrinkage of this tumor from the size of a grapefruit to about like that big in a very short period of time. And when he was operated upon, none of his lymph nodes were positive. This was an excellent result, and it was due to his, number one, reticence to have much of anything done, except taking just a few elements, but having some kind of preparation and shrinkage of the tumor mass before he had a surgery. I now have a case where the patient has type 1 diabetes. She was told for 2 years that the lump in her breast was benign. However, on physical exam, it was a tumor. I had her get a PET-CT scan, and we discovered that there was not only a tumor in her breast, but there's also a tumor in her liver. So her first-time diagnosis was stage 4. Now this patient, as again I say, has type 1 diabetes. That means that her wound healing is very impaired. Despite the fact that she's been very, very careful and she knows how to take care of her body extremely well, this poses a threat to her. She refused to get a biopsy. So I devised a situation where she could get preoperative treatment, which is very effective, and then have brachytherapy, both in the breast and in the liver, and at the same time get a tissue biopsy so that we would know exactly what the receptor status was in order to advise her fully what other treatments might be most helpful to her. This is very important because making a large surgery in a patient like this initially would cause a lot of complications with poor wound healing. So again, it's all a matter of strategizing for success. And when you get preoperative treatment and really sound, thorough preoperative evaluation, that's going to make your result more successful. And I truly believe will diminish this rapid recurrence situation that so many patients are now involved in. They do the surgery, they have the chemo, they might even get post-op radiation, and voila, they get a recurrence 6 to 12, 24 months later and wonder why. All has to do with careful preoperative evaluation and preparation to optimize the result. Thank you.